Welcome to this webinar sponsored by Bioventrix. New developments in structural heart therapy, attacking the progression of heart failure less invasively. Bioventrix is a privately held medical device company based in San Ramon, California, near San Francisco. Bioventrix designs and manufactures devices for treating congestive heart failure. The vision of Bioventrix is to become the market leader in developing minimally invasive, catheter-based solutions for treating ischemic cardiomyopathy. The company's first-generation device is called the Revivent Myocardial Anchoring System. It consists of Anker-based technology for plicating left ventricular antero-septal scar in post-myocardial infarction patients, thus restoring the left ventricular shape, size, and pumping efficiency. The left ventricular remodeling is achieved through a novel procedure that's known as LVAD, Less Invasive Ventricular Enhancement. Our program includes 3 key opinion leaders: Dr. Stefan Anker, Dr. Serenella Castelvecchio, and Dr. Andrew Wechsler. Dr. Anker will get us started with an overview of heart failure. Dr. Castelvecchio will follow with a STICH update and SVR overview. Dr. Wechsler will discuss less invasive ventricular enhancement. And Dr. Anker will summarize the key learnings from today's webinar. Webinar objectives are 4. First, acknowledge limitations of current therapies. Second, educate about recent STICH analysis. Third, build awareness of Bioventrix and positive clinical outcomes. And fourth, inform about future TransCatheter technology. Now, Dr. Anker, will you please begin?
Good day, everybody. I have the great pleasure of talking to you today about contemporary treatment of ischemic heart failure. My name is Stefan Anker, and I'm the president of the Heart Failure Association of the European Society of Cardiology. I will review together with you the therapeutic options, the outlook of these patients, and some of the new issues regarding the guidelines. When you study the contemporary treatment options in heart failure, one needs to consider this in the context of the poor prognosis of these patients, the challenges that can be seen by CRT responders and non-responders, the quality of life economics of left ventricular assist devices, heart transplantation, and then in the end ask ourselves, what can we actually really do that is new for these patients? In 2012, the European Society of Cardiology and the Heart Failure Association within that society published the new 2012 guidelines for the diagnosis and treatment of acute and chronic heart failure. This work was led by Professor John McMurray from the United Kingdom and consisted of a group of people that worked together trying to develop these guidelines, a great number of reviewers and independent support persons. So this is the up-to-date, state-of-the-art information we can provide you from a European perspective. Compared to previous guidelines that were published in 2008, there are several new features in our guidelines. Our guidelines have a new diagnostic algorithm. Our guidelines now have a revised section on acute heart failure, and we link evidence very strictly with the new recommendations. And particularly some new information is part of our guidelines regarding the therapy of patients with acute and chronic heart failure when it comes to pharmacological therapy, device, and surgical treatments. The new diagnostic plan that we suggest to follow for patients with heart failure distinguish mainly between acute onset and non-acute onset heart failure. These patients can be assessed with a strategy using echocardiography first, shown in blue, or natriuretic peptide hormone assessment being used first. As you can see, this is indicated in red. Whatever you do a full clinical assessment in these patients. The flowchart here also indicates the different cutoffs that you want to use for natriuretic peptides. And as the most important new piece of information, we can now also say that besides brain natriuretic peptide and anti-brain natriuretic peptide, we now have a third natriuretic peptide, which is mid-region pro-ANP, that is found to be non-inferior to BNP and anti-BNP in the BUFF study. Let me now summarize some of the new therapeutic options we have that are an advance beyond the 2008 guidelines. First of all, and this is a really important issue, we have some expanded indications for mineralocorticoid receptor antagonists. Second, we have in Europe, and this is unlike what you can see in the United States, we have a drug that reduces the heart rate of patients. That drug is ivabradine. In our guidelines and in the trials, we know that this drug works when heart rate is above or equal 70, but we have to also consider that the European Medicines Agency approved this drug only for patients with a heart rate above or equal to 75 per minute. As I mentioned already, we also have an expanded indication for CRT therapy, and interestingly, we have in our new guidelines expanded information on coronary revascularization in systolic heart failure. There is a recognition of the growing use of ventricular assist devices, and I will give you some more information about this. And of course, we have MitraClip and other new technologies that are for the first time mentioned in our guidelines. When you consider the use of pharmacological therapies in the setting of symptom relief and congestion and trying to improve prognosis of patients with systolic heart failure, first of all, the mainstay of our therapy is ACE inhibitors and beta blockers. When patients remain symptomatic, then of course we should use also mineralocorticoid receptor antagonists. Do they stay symptomatic still and have they continued systolic dysfunction with ejection fraction of 35% or less and a heart rate that is increased beyond 70 beats per minute, then ivabradine should be used. All these indications are very strong indications for the use, and ACE inhibitors and beta blockers and mineralocorticoid receptor antagonists are 1A indications. Now, with all these many good drugs we have, we still see that outcomes in patients hospitalized with heart failure are still poor. Some years ago, it was found that the 30-day and 6-month readmission rates after a hospital admission are 20 and 50% respectively. The mortality of such patients is as high as 33% in 1 year. When we now compare this with patients studied in trials that are much more contemporary, we see that there are still many, many events in such patients. And indeed, there's not only the recognition that many patients have single events, but indeed many patients have more than one event. And here in this example of a small study that really depicts this in a very interesting way, you can see that such events can be heart failure hospitalizations, myocardial infarctions. It can be the implantation of an assist device, but of course also transplantation and possibly death. When you then study this in big trials, like in the SHIFT trial, you can see here that over a period of approximately 24 months, there is a cumulative incidence of heart failure hospitalizations, first and repeated, of at least 30%. Now, some of our therapies can, to some smaller degree, reduce this, but still there is a lot to do that we need to improve in patients to reduce the recurrent many events that we see in these patients. When it then comes to using technologies beyond drug treatments, of course, the use of CRT and ICDs is also indicated in heart failure patients who are symptomatic and who have a low ejection fraction, and particularly the use of CRT is reserved for patients with a prolonged QRS. If you have also patients that are at risk to develop arrhythmic death, then of course you should also consider implanting ICDs or combination devices. It is important to consider in the context of finding the indication for CRT therapy whether or not the patient has a left bundle branch block QRS morphology. If the patient has indeed this morphology, then a QRS duration of at least 130 milliseconds should be used to find an indication for a CRT device, and then we know that this therapy will reduce heart failure hospitalizations and death, and this is a clear 1A indication. In the context of having no left bundle branch block morphology, we are then demanding that the QRS duration should be at least 150 milliseconds for achieving the same effect, which is reduction of heart failure hospitalization and premature death. There are, of course, limitations to the use of CRT therapy in heart failure. There is cost, there is a number of patients that don't actually have prolonged QRS, and there is, of course, a big number of non-responders. At least 30 to 40% of patients who receive a CRT are complete non-responders. And in many patients who actually have an ejection fraction between 35 and 50%, there is no therapeutic option as CRT is not indicated in them. Interestingly, we also now have a new modality for patients with mitral valve problems. The MitraClip therapy is now, after the first studies that were published, a therapy that should be considered in a number of patients, but the overall experience is limited and we need to know much more about this therapy. But as a step forward, we are now suggesting that this may be considered in patients with unacceptably high surgical risk who have heart failure. It was found that such percutaneous interventions may provide short-term improvement in functional conditions and in left ventricular function, and overall we believe that this is a useful approach in some patients, but nevertheless these findings need to be confirmed in larger series of patients with longer follow-up. Indeed, such a study is currently taking place, and the trial is called Reshape HF. Now, coming then to the most, let's say, expensive advanced therapy for the patients with severe heart failure, we need to consider left ventricular assist devices. They are a very important therapy for a small group of patients. They improve the one-year survival of advanced heart failure patients. This improvement comes at a high cost. You need to consider that for each quality of life adjusted life year in these patients achieved with this therapy, you spend approximately 200,000 euro, which is at current exchange rates about 270,000 US dollars. This is a good therapy for a small number of patients, but at a very, very high cost. Now finally, for an even smaller group of patients, there's heart transplantation. You see here some data of the International Society for Heart and Lung Transplantation, and this data, being the most recent 2012 published data, is showing that over a long period of time since the early 90s, there is initially a decline and now a stable number of heart transplantations worldwide as recorded in these summaries of about 3,800 such operations. You can see that considering the millions of patients with heart failure, the many, many hundred thousands of patients with advanced ischemic heart disease and severe heart failure, this is a tiny amount of therapeutic interventions of this kind. The outcome of patients being transplanted has improved over time, but still, even there, you see after 2 years that approximately 20% of patients are dead, even receiving this therapy, but we need to also consider again that this is for a small minority of such patients. When you want to study the post-transplant morbidity, we now know that these minority of patients receiving transplantation have a rather good outcome overall at 1, 5, and 10 years post-transplant. they have a number of, then in the long run, observed dysfunctions of the kidney, of the metabolic system with diabetes, but they, of course, also develop hyperlipidemia. So these are patients that have complex metabolic changes and live with the new heart a long time, but under intensive medical supervision. Now, let me summarize the therapeutic options for ischemic heart failure as I've outlined to you. We have optimal medical therapy, including several different drugs, ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists. Second, we have then, of course, CRT therapy with or without ICD in addition, but we need to understand the limitations there. We have, for a subgroup of patients, a small group of patients, we have left ventricular assist devices. These are coming at a high cost and are effective over shorter periods of time. If you want to have a solution for advanced ischemic heart failure that is a long-term solution, then heart transplantation is the only option. However, this is for an even smaller subgroup of patients. Only about 4,000 patients per year can receive this. I believe there is such an overwhelming epidemic of patients with ischemic heart failure that we need to find new ways of treating these patients. One option could be to reconsider surgical ventricular reconstruction. But if we want to do this, of course, the big question is how, and of course, the next question is who should receive this therapy. And I believe the next talks will guide you towards this goal.
Dr. Anker, we have a couple of questions from the audience. The first question we have is, do you foresee the use of Revivent in combination with MitraClip?
Thank you for this question. This is an interesting option that I believe should be considered, should be studied. I personally foresee this option as a possibility, but at this moment, of course, we have no experience with this in practice. But it should be extremely interesting to study this.
And we have one other question for you, Doctor. Are the Revivent and MitraClip technologies compatible?
Personally, thank you again for this question. Personally, I think they could be compatible, but we need to really study them in more detail. I can't really see why this should not be possible, but I think we need experienced operators and we need some evidence base to make clear statements about this. But in principle, yes.
Thank you, Dr. Anker. Our next presenter is Dr. Castelvecchio.
Good morning, everybody. I am Dr. Serenella Castelvecchio, a cardiologist working in Milan. The title of my talk is an updated analysis from STICH, patients that benefit from surgical ventricular reconstruction. It's a pleasure for me to go a little bit deeply in the complex matter of surgical ventricular reconstruction for patients affected by heart failure. The increase in left ventricular volume after myocardial infarction is a component of the remodeling process, and it is associated with a poor clinical outcome. Surgical left ventricular reconstruction has been developed with the aim to exclude scar tissue from LV cavity, thereby reducing the ventricle to a more physiological volume and improving cardiac function through a reduction of left ventricle wall tension according to the principle of Laplace law. As wall tension is directly proportional to LV internal radius and pressure and inversely proportional to wall thickness, any intervention to optimize this relationship could be beneficial either in terms of improving wall compliance and reducing field pressure, or, as wall stress is a crucial determinant of afterload, in terms of enhancing contractile performance of left ventricle by increasing the extent and velocity of systolic fiber shortening. Several studies have shown that surgical ventricular reconstruction is effective and relatively safe with a good 5-year outcome. However, in spite of the large number of reports from registries and mainly observational studies, data from the largest randomized trial, the STICH trial, have questioned the real additional benefit of SVR in respect of coronary artery bypass grafting alone. With respect to the restoration hypothesis, the trial showed no differences in the occurrence of the primary outcome between the two groups. The primary outcome was a composite outcome of death from any cause or hospitalization for cardiac causes. Next slide. However, the combined procedure resulted in a significantly larger reduction in LV and systolic volume index compared to the CABG-only group, 19% versus 6% respectively, but smaller than in previously reported observational studies. Why STICH failed? Of course, the patient selection is the first matter of concern. If you look at the study design changes introduced after 1 year of enrollment, you can see that requirement for advanced heart failure symptoms dropped. Furthermore, the design of the trial initially excluded patients with an LV and systolic volume index less than 60 milliliter per meter squared. 1 year later, it was decided to liberalize inclusion criteria to include patients amenable to surgical ventricular reconstruction in the opinion of the investigators. Changing the inclusion criteria led to apply the concept of surgical ventricular reconstruction to a larger ischemic population with low ejection fraction independently of heart failure, in which SVR has known effects. The ejection fraction remained the main inclusion criteria, too little for choosing the good patient. Furthermore, removing the lower value of end-systolic volume index to make the selection led to the inclusion of patients with a broad range of baseline end-systolic volume index, ranging from 22 up to 231 milliliter per meter squared, reinforcing the question of which ventricles have been randomized in this trial. Nevertheless, the assessment of viability should have been mandatory in this trial to look at the scar and to better identify those patients who could benefit from SVR at best, while it remained an option. Furthermore, registry enrollment was discontinued. The relative small percentage of left ventricle and systolic volume reduction observed in the combined group raised concerns over the extent of surgical ventricular reconstruction procedure that was applied in this trial. To better understand this point, our group reported the impact of survival of a residual end systolic volume index greater or less than 60. We selected the study population according to the original inclusion criteria of the STICH trial, and we show that LV and systolic volume index following SVR does impact on the probability of death, being significantly higher in patients who remain with a postoperative end systolic volume index of greater than or equal to 60. we hypothesized that the lack of additional improvement in terms of survival in the SVR group observed in the STICH trial may be due to the inadequate volume reduction, which left the patient in the two arms at identical risk. So far, 1 year later, the surgical ventricular reconstruction has been endorsed by the European Task Force on Myocardial Revascularization to be considered as a surgical option combined with coronary artery bypass grafting in selected patients affected by ischemic heart failure and LV dysfunction, either in patients presenting with angina and LV and systolic volume index greater than 60, or in patients presenting predominantly with heart failure symptoms. The prognostic value of post-surgical and systolic volume index has been further confirmed by this European group in 2011. In the meantime, the STICH investigators started to go deeply in the data analysis, confirming the negative impact of end-systolic volume index on 5-year survival. Soon after, Wechsler and colleagues analyzed the LV volumes at baseline and 4 months after surgery, showing a survival benefit in patients treated with CABG plus SVR, with the achievement of a postoperative end-systolic volume index of 70 milliliters per meter squared or less, supporting for the first time the role of surgical ventricular reconstruction in the treatment of patients with ischemic cardiomyopathy.
Thank you for your presentation, Dr. Castelvecchio. We have a question from the participants. The question is, given the new STICH analysis showing a survival benefit, what kind of patient is ideal for SVR in terms of symptoms and morphology?
Oh, well, regarding symptoms, I think that patients should be symptomatic mainly for heart failure. It could be better than a patient show a functional class 3 or 4. Regarding the morphology of the ventricle, this is a tricky question, but I think that looking at the sub-analysis of the STICH trial, it's necessary to have enough volume before the operation in order to make the reduction. So, preoperative and systolic volume index should be above 60 milliliters per meter squared. And of course, the condition sine qua non to apply this type of surgery is the presence of the scar.
Thank you, Doctor. We do have one more question. That question is, what imaging tools do you use for the screening process to identify left ventricular scar?
Of course, cardiovascular magnetic resonance is the gold standard imaging technique to assess myocardial anatomy, regional and global function, viability, and more importantly, infarct size, and percentage of transmurality determined by late gadolinium enhancement. For the scar, it's out of doubt that magnetic resonance is the gold standard imaging technique. Of course, there is the problem of patients with device like an ICD or biventricular pacing for which this technique is not suitable, but when it's feasible, cardiac magnetic resonance should be the gold standard.
Thank you, Dr. Castelvecchio. Our next presenter is Dr. Wechsler.
My name is Andrew Wechsler. I'm a practicing cardiothoracic surgeon and consultant to Bioventrix. I'm going to be speaking with you about the less invasive ventricular enhancement procedure. In the course of this conversation, I will describe the Revivent Myocardial Anchoring System. I will present the early clinical data that was used to obtain CE mark approval. I'll discuss some data on durability. I'll show you the evolution towards a TransCatheter concept and what we believe is the effect on the treatment pathway. At the moment, there are two Bioventrix solutions, one that has been tested extensively in man, and the second which is just getting ready for testing in man. The first is an epicardial-based myocardial ventricular restoration procedure that requires a median sternotomy. It's designed for off-pump use, but it can be used with cardiopulmonary bypass, and which employs a series of epicardial and right ventricular-based anchors to plicate and exclude scar from the ventricular contractile chamber. We have a Phase 1 clinical study that has been completed, and we are continuing recruitment for an ongoing registry. On the right hand of this slide, you can see the next iteration of this technique. We will use exactly the same Revivent myocardial anchoring system. The difference, however, is that this method employs the services of both a cardiothoracic surgeon and a cardiologist. It is done entirely with a chest-closed procedure, combining a transjugular approach by the cardiologist and a thoracoscopic approach by the cardiac surgeon. Extensive animal studies have been performed in this procedure, and the first in man is immediately pending. Regardless of which method is used, the patient population is the same. Treatment is designed for those patients who have dilated hearts with a left ventricular antero-septal scar from a prior myocardial infarction. This may be performed with or without accompanying coronary bypass grafting. Ejection fraction should be reduced, and there should be a distinct akinetic or dyskinetic antero-septal scar, usually demonstrated on magnetic resonance imaging with delayed gadolinium enhancement, as is shown on this slide. Patients may or may not have implanted resynchronization devices or defibrillators. Conceptually, the Revivent procedure is very simple and not different from that described by Dorr. The goal is to exclude the scar demonstrated in this slide by the thinned and white myocardium from the left ventricular chamber, and to bring adjoining areas of contractile myocardium into apposition with one another, as shown on the right-hand side of this scar. This reduces the left ventricular volume, and in particular reduces the radius of the left ventricle in the circumferential axis. A schematic of the procedure is shown in this animation. The gray in the beating heart represents the scarred myocardium, and the left anterior descending coronary can be seen. A needle is introduced at the periphery of the scar on the anterior surface of the ventricle and the septum, and a wire passed into the right ventricle or out the pulmonary outflow tract. A dilator is passed over that wire and across the septum, and the dilator is then removed, and a 2.5 centimeter polyester coated titanium anchor is aligned along the long axis of the left ventricle against the right side of the interventricular septum. A final anchor is placed over a ratcheted PEEK catheter and tightened. This is done along the length of the left ventricle thereby excluding the scarred material with alignment of the anchors on the right ventricular surface as well as the epicardial surface. The consequence of this is demonstrated in this magnetic resonance image from a preoperative study and a postoperative study. The characteristics on the left-hand side can be noted with a grossly dilated left ventricle and a rounded, poorly defined apex, very typical of these patients. On the right-hand side, the postoperative image demonstrates the neo-apex and the much smaller left ventricular volume. The Revivent Myocardial Anchoring System was done first in man and now has completed a phase 1 study. The critical entry criteria in the phase 1 study were that it was a non-randomized, single-arm, prospective, multi-center trial. Our goal was to enroll 30 patients with follow-up visits at 1, 3, 6, and 12 months. And after obtaining Ethics Committee and Ministry of Health approvals, study sites were chosen in Poland, Lithuania, Latvia, Russia, and Austria. The most important results of this phase 1 study were the highly effective reduction in left ventricular and systolic volume index as demonstrated on this slide. The red arrow points to the very consistent 36% reduction in end-systolic volume index. Other parameters that were followed included end-diastolic volume index, which was reduced, as well as ejection fraction, which increased modestly. Most importantly, the functional criteria improved in these patients with an improvement in the quality of life questionnaire, essentially a one-step improvement in New York Heart Association classification for heart failure, and a dramatic 22% improvement in the 6-minute walk. With the success of this first portion of the project, using the exact same technology for excluding scar from the left ventricle, a TransCatheter method for performing the operation was developed. You will shortly see a movie that animatedly describes this procedure. However, I wish to point out that this is done jointly by a cardiothoracic surgeon using a thoracoscope and a cardiologist using a transjugular venous approach. The same beating heart figure is shown, and a catheter is placed via the right internal jugular vein, which is a standard foreign body removal catheter. A 7 French needle is introduced across the left ventricle at the edges of the scar, through which a wire is passed. This is done thoracoscopically. The wire is captured by the foreign body catheter and brought out through the jugular vein. The anchor is then passed along this catheter and pulled against the right side of the interventricular septum. Once again, an external anchor is placed by the surgeon, and the scar is compressed and excluded from the left ventricular contracting chamber along the length of the left ventricle. It's important to note that the epicardial hole made by the needle is much smaller than in the epicardial approach, so that hemostasis is not a problem. This last slide demonstrates the way that we believe having a much less invasive therapy will influence the management paradigm for patients with congestive heart failure who have anatomy suitable for ventricular restoration surgery. A very typical cycle for a patient with heart failure and a large scar is shown here. Patients typically move from class 1 through Class 2 and are seen by heart failure cardiologists when they are in Class 3. Most patients respond well to medical therapy at this point, and some patients who require readmissions for heart failure require implantation of a ventricular resynchronization device or internal defibrillator. Characteristically, these patients improve, but their improvement waxes and wanes, and they move between Class 3 and Class 4 cardiac failure with limited ability to perform daily activities in either of these functional classes. Inevitably, these patients deteriorate into solid Class 4 patients for whom little therapy is available. With a less invasive treatment available, patients who are late Class 2 or Class 3 may be considered for ventricular remodeling procedures or ventricular restoration surgery after 1 or 2 admissions for management of heart failure. And these patients will be restored to functional Class 2, as was the case in our Phase 2 clinical trial and ongoing registry. Thank you very much for your attention.
Thank you, Dr. Wechsler. It looks like we have 3 questions for you. The first is, can Revivent be performed concomitantly with CABG, and can it be done on pump?
Yes, absolutely. Revivent was designed so that it could be done without cardiopulmonary bypass and without ventriculotomy. But for safety reasons, many of our early patients were done with cardiopulmonary bypass. As a result, Revivent can be combined with either off-pump coronary bypass grafting, on-pump coronary bypass grafting, as an accompaniment to on-pump mitral valve repair, shortening both the ischemic time and the pump time.
And we have a second question. What happens to the blood in the excluded cavity? Is there communication with the rest of the ventricle?
In both animal studies and 1 human examination, there is complete exclusion of the scarred cavity from the left ventricular contractile chamber, exactly as is the case with a conventional surgical door procedure. Therefore, there is no concern regarding thrombus in the excluded cavity.
And our final question, how do the clinical results and benefits of Revivent compare with traditional SVR?
The most critical factor in determining outcomes after SVR is the extent to which left ventricular and systolic volume index is reduced. Using the Revivent technology, these reductions average 36%, far exceeding the results obtained in STICH and matching precisely the results obtained in multiple observational studies performed by many investigators prior to and during the STICH trial. A great difference, however, has been the avoidance of bypass and ventriculotomy, the consequence of which is much less blood usage and also a shorter intensive care stay.
Thank you, Dr. Wechsler. Dr. Anker, do you want to provide us with a summary of today's webinar, please?
Well, today we have learned that there is a great new option for patients with ischemic heart failure, which is that maybe we can in the future, in a very effective way, do surgical ventricular reconstruction. This could be done in a more efficient way than ever done before, and with a reasonable degree of invasiveness that could still be acceptable for a number of patients. I believe this is a therapy that could be used in conjunction with other therapies we have already. Now, what we really need, of course, is prospective studies. We need to see whether this works when done in a controlled setting, but I'm optimistic that we can achieve this, and I would like to thank Bioventrix for giving us the chance of this symposium being shown to you, and maybe you can all help us in creating in the future the evidence base that we need to have this possibility of better therapies for our patients come true. Thank you so much for your attention.
Thank you, Doctor. Thank you, Dr. Anker, Dr. Castelvecchio, and Dr. Wechsler. This concludes our webinar brought to you by Bioventrix. For further information about Bioventrix, please visit www.bioventrix.com. Thank you.